started the second day of the second scientific day of our conference. And the first lecture is for Dr. Police Tahbala. He is one of the victors in the origin in Jordan. And in brief, I tried to introduce him. He is graduate of Westminster Medical School, London, Imperial College Medical School, trained in neurology also in the United Kingdom, fellow of the Royal College of Physicians, specialist registered in neurology, London, past president of Jordanian Society, previously part-time associate professor of clinical neurology at the Jordanian University Hospital and Medical School, past honorary consultant neurologist at the St. Mary's Hospital, Imperial College Medical School, London, United Kingdom. At present, consultant neurologist, Charity Hospital, Medical Center, private practice. Special interests include management of acute stroke, multiple sclerosis, movement disorders, and Jordanian vaccine use, dystonia, and spasticity. Please welcome Dr. Police. He'll talk about the management of acute histories. Please.
Good morning, everyone. Thank you very much for your kind introduction. What I'm going to do for the next 20-25 minutes is to give you just an overview of the management of acute stroke in 2014. Now, I think, as we all know, the management of acute ischemic stroke in Jordan needs a lot of changes. It is very badly managed. We still do not have stroke units. We are not updating our management of patients in acute stroke, although acute stroke in Jordan forms a major issue, not only in incidence and prevalence, but also as a major cause of disability. I will try in the 20 minutes to convince you that we should be changing dramatically our management of acute stroke in Jordan. I hope at the end of this talk you will agree in a short period of time I can show you a few of the updates on the management of acute stroke that is going on all over the world. This is just to summarize to you, just straight away, what is the outcome intervention supported by class 1 evidence proven to improve outcome. And you can see here, we can summarize them very quickly with this slide. All patients with acute stroke should be managed in an acute stroke unit. You have to have there's been a lot of research going on, a lot of data. There's no need to do any more research in this. It is well established now that all patients with acute stroke should be managed in the context of a stroke unit. Now, this can be a hyperacute stroke unit or an acute stroke unit, and there are different types. But if you manage them only in the context of an acute stroke unit, even without using thrombolysis, you will improve outcome at least 30 to 40%. The second one, I will not discuss it, is very well known that all patients who have acute stroke, it is standard practice to give them aspirin in the first 48 hours, and that shows some benefit without any question. That is standard treatment. The other one, which is also now standard treatment, is the use of thrombolysis intravenously. It used to be within 3 hours, now it's been extended to 4.5 hours, and there is the IST3 data, which suggests maybe up to 6 hours, but there is controversy about increasing that to 6 hours. Also, I will mention quite a bit about this later on because it is important, but only thrombolysis will be used in eligible patients. Unfortunately, not many patients come quickly enough to hospital to receive this treatment, which is life-saving and sometimes produces really dramatic, excellent results and prevents disability. One of the other things that has been shown to be really of value is doing hemicraniectomy, which is now the anti-edema therapy of first choice for patients with large middle cerebral artery infarction aged 60 years and below, particularly non-dominant hemisphere. And in the Destiny 2 trial, which was recently published, this seems to have, we can extend this maybe to even 80 years. The use of heparin in the treatment of acute stroke is been used for the last 40 or 50 years. It was a lot of standard practice to use heparin in all patients with stroke. But this should not be anymore. We should not use heparin in the management of acute stroke. And there are expert opinion on this when you can do that. I will go very quickly through this. I'll just put up here some of the indications where people think you may benefit from giving patients heparin in the early stages of a stroke, like atrial fibrillation, with proven intracardiac thrombus, artificial valves, left atrial ventricular thrombi, myocardial infarction, symptomatic dissection of the arteries of the brain, symptomatic extracranial, intracranial arteriosclerosis with crescendo TIA, where you're afraid that the patient's going to stroke, or progressive stroke, but basilar artery occlusion, for example, before or after intraarterial pharmacological or mechanical thrombolysis, and known hypercoagulant states, like, for example, protein SC deficiency, etc., and cerebral vein thrombosis. So these are indications that one might consider doing that. But you have to be careful and choose the patient correctly. If you, for example, see somebody who's got a large infarct, more than 1/3 of the hemisphere, you have to be cautious and you have to really delay it for 1 or 2 weeks or even more. And the incidence of having a stroke, if you have an AF, is about, of having a stroke in somebody who has AF, for example, is about 0.3 to 0.5% per day. So the risk is small. I think one has to be very cautious in using heparin in the acute setting. Now, what I want you to see now, I want to present this patient, who is Mr. K.N. He was aged 84. He was brought to the emergency room in 2011 at 11 p.m. And it seemed that at 10:20 p.m., which is 40 minutes before he was arrived, he suddenly had difficulty with speech, weakness of his left side arm, leg, associated with increasing difficulty with swallowing. He was choking in his own saliva, actually. He was having difficulty breathing. The only risk factor he has was hypertension, no diabetes, heavy smoker, and his medication was clandestine. And he was in examination, he was in distress, repeated coughing because of choking, dysarthric, weakness of the palate, horizontal nystagmus, impaired gaze, and he had this left-sided weakness and hemiplegia 2 or 3/5. And the thing which was really dramatic was his blood pressure. His blood pressure was 240/120. Basically, the CT scan that was done was normal, there was no hemorrhage at all, and he basically fitted the criteria to give TPA except for the high blood pressure. And in those cases, you need to control the blood pressure in the context of an acute stroke unit, because you need to monitor the blood pressure carefully. You have to bring it down to 180/100, and then you can give thrombolysis. And this is exactly what we did. This is his CT scan, doesn't show any hemorrhage. You can see actually, this is, I think it's not the first scan we did on him, but anyway, it was normal. On this scan, you can see a bit of hypodense area on this side of the scan. And this is, we did an MRI while we were waiting. Actually, we were worried about this. We started giving him anti-hypertensive drugs. We managed to get a very quick, limited MRI to see exactly what was happening. And this was, you can see here, this area on the diffusion scan, and there is some bit in the lateral part of the medulla down here. You can see some changes there. So he was admitted to the hyperacute stroke unit at the Khalid Hospital, and he was given a little to control his blood pressure. Once that was done, he was given TPA. So we gave him a usual bolus of 0.9 milligram per kilogram, and usually in patients you never go above 90 milligrams in any patient. You give 10% bolus, and then the rest over 1 hour. And he was given, the drug was started 90 minutes after onset of symptoms. And this is very important. When you are treating patients using TPA, you have to make sure you are using it early. Although the window is up to 4.5 hours, and some people may take it to 6 hours, still the best results are when you do it in the first hour, first 1.5 hour. The longer you delay, the worse the outcome. Okay? And so I will show you now the video of this patient before and after TPA, because I think it is a good. Now let me make sure I don't make any mistakes there.
Open your eyes. Open your eyes. Look to the right. Look to the left. To the left. To the left. Look up. Look up. Look down. Look down. Look to the right again. Look to the left. Okay. Now close your eyes. Tight. 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 Close your eyes tight. Open. Open. Show me teeth. Show me your teeth. 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 Yes. Yes. Now raise your left arm. Put your arm up. 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 Okay, fine. Left leg up, up. Okay, right leg. Okay, left leg.
Okay, let's do the other one now. Now he was given TPA, and this is the next morning at about 8 a.m.
حركيين الشمال طبعا الاخر انه تقدر تروح حركيين شمال هلا بدك ترفع ايدك الشمال ترفع ايدك افتح راسك نزل ايدك
So he's recovered dramatically by the next morning. I think for the sake of time, I'll just stop that. I made the point. And show you, go back to the presentation. This is him actually having breakfast, because after I saw him in the morning, we did a test on him and he could swallow, and he actually had breakfast, and his swallow was perfectly okay. Even he's using now the left hand, which was weak. Can you see it from where you are? I'm not sure whether you can. Can you see it? You can? Okay. It's not dark there. Yeah. So he was just demonstrating how good his left hand is. Okay, I'll stop that just to go next. This is before he left. We did just a follow-up CT on him, and you can see, of course, that there is a remaining hypodense area on this side, on this left cerebellum, and higher up a bit. But probably we can't see here the brain stem, but maybe he had a complete recovery of the brain stem. Maybe we saved his brain stem, and that's why he's better. This is a day, he was in the hospital on May 19th, and he was 10 days out of the hospital. He went went out, and he had a bit of, I won't show you this for the sake of time, but he had a bit of ataxia when he left, and this is him. I will show you this one, 37 days after, and that's him, after 37 days of being in the hospital with this acute stroke, which involved his brainstem, okay? And so we go to the next one. This patient, very quickly, why I put this patient in is just to send a message that before we used to say patients would be treated with TPA between the ages, above the age of 18 until 80. But now, this 80 has been removed. Of course, in the initial NICE trial, all the patients between 18 and 80. In the ECAS-3 trial, which extended the window to 4.5 hours, they put, in fact, one of the differences between ECAS and the NICE trial was patients above the age of 80 were excluded. But then, and also they excluded patients with severe strokes, they also excluded patients who had previous strokes and diabetes, and patients who were on anticoagulation irrespective of their INR. This patient was 91. She was transferred from another hospital, sudden difficulty with speech, complete weakness of the right arm and leg. She had cardiac arrhythmia. She was seen by a cardiologist who recommended a pacemaker, but no treatment was given. She was not diabetic, not hypertensive, not smoker. In fact, she was in excellent shape. And according to her 88-year-old brother, she was single, living with him, and she was very active. She was doing her own shopping, visiting her friends. When they asked me to see her, I said, you're 91, what are you going to do for a patient of 91? Basically, when I saw her, she had pulse of 42, blood pressure was okay. She basically fitted the criteria, except, the time was marginal. Should we give her something, should we not? Her CT scan was normal, and all the tests, all her hematology parameters were good. But she had a dense hemiplegia, she was aphasic. And this is we managed to get a CT scan, which was normal. And then we did, as usual, sometimes what we do is a very limited MRI. We do a diffusion to see if we get, but only you can see these areas. Although the deficit was massive deficit, but on diffusion we didn't see very much. And one of the ways in which you can decide whether the perfusion area, between perfusion and diffusion, whether there are still areas that you can salvage, is to look at this and do perfusion, or in fact look at the flare scan. And if there is a flare diffusion mismatch, you may be able to say, okay, maybe there is time for me to work. But basically, I put it to the family that this is a very difficult situation. The only reason, because she was active before, I offered them to give them thrombolytic therapy, despite the fact that with all the different, I explained to them exactly what is expected. She may have bleeding and so on. But they elected to go ahead and give her the thrombolytic therapy. So I gave her TPA, and this is her first one here. When she came in, شهلة دوري طلع علي ورجيني لسانك شهلة ورجيني لسانك. She wasn't basically responding. ورجيني لسانك شهلة ارفعي ايدك الشمال ارفعي ايدك الشمال يلا. She was completely aphasic. She couldn't respond. She couldn't express herself. Her eyes were looking to the left. It was really, in those in most of the studies that you see, when you have a massive stroke, you worry about giving them treatment like this. But the problem is you don't have much of a choice sometimes. Anyway, in this case, I'll stop there and I'll put this here. I'm not suggesting that you give patients TPA at this age, but the point I'm going to make is this, is that depending on the circumstances and on each case that you see, this is her the next day. تمام؟ أحسن. ليش هدول؟ قديش؟ هدول طلع. وهلا؟ Okay. I will stop there just to make the point. I will show you her coming 2-3 weeks later to the outpatient. This is her.
سنة.
I think she probably go in the Guinness Book of Records. Okay, this is the MRA before, and you can see here on the left side there's not much flow going, and this is after the TPA. Now we come back after this just to quickly look at what is the burden of stroke, particularly in relation to Jordan, what we can do. Obviously, I'm going to go very quickly here, and I'm sorry that I have to quickly go through these slides, just making 1 or 2 points as they go along. But basically, there's quite maybe in this year, there's about 5.7 million people dying from stroke. This is going to increase to almost 8 million by 2030. It affects about 15 million people all over the world. 5 million will die, 5 million will have a major disability from these. This is a recent article, the global burden, regional burden of stroke during this 1990 to 2010, and this was published in the Lancet this year, 2014. And here, I put this on because it shows the area where Jordan is. It's here, where it is one of the highest, supposed to be. I don't know what the data depending on, because I think the data in Jordan is not very accurate. But this one here is supposed to be a high risk of very high incidence and prevalence of stroke. And if you look here, so we are 251 to 336 per 100,000. And we are supposed to see 16,000 to 22,000 cases of stroke a year. But it's quite high. Why is it important? Because 30% will die, 1/3 of these deaths below the age of 70, and I think the recent study saying maybe 50% below the age of 60. The average life expectancy in Jordan is about 70 for men, for females, and 65 for men. It's lower than it is in the rest of the world. Now, all these deaths occur in low to middle income countries like us. You know, we are supposed to be a middle income country, unable to afford stroke units. Unfortunately, we have only one stroke unit in Jordan. We should be having one everywhere, in the King Hussein Medical Center, in the university, everywhere. And about 55% of these strokes are having a disability. So basically, it shows you how important looking at this issue. This is a paper I picked up from in May 2012. This is from Dr. Saleh Al-Urayni, who now works in Saudi Arabia. He worked at the Bashir Hospital, and he did a retrospective study of the patients that were admitted with stroke over the last 3 years. And he collected almost 1,300 patients, and you can see the distribution of them here. Not any above the age of 74, which is a bit funny, because I don't think that must be right. And you can see men here are more than females, and also that quite a lot of them are below the age of 54, you know, about 30% or more. And here, this is showing you males are more than females, and about almost 30% below the age of 54, and 60% below the age of 54 sorry, here, and 64 here. Now, 81 were first strokes, and 17% were second strokes. And this is, there's no data on this ischemic and hemorrhage, and this is what really shocked me, is that when he was looking at these risk factors of patients at Bashir Hospital, no data on 41% of patients. Unbelievable. You know, they didn't have anything in records about whether they had high blood pressure or diabetes or heart blockers. And if you look here, as an example in Jordan, the other thing which was surprising is the majority of patients were discharged within 3 days, which means they didn't have much of a treatment, as far as I'm concerned. And about 20% requested early discharge against medical advice. And the length of stay was about less than 1 week, the majority of them. Now, if you look at the international proper stroke unit and management of stroke, you are talking about an average patient stay in hospital between about 8, 10, 14 days, some 20 days. The best country in the world to treat stroke is Scandinavia, where 80% of the stroke patients are treated in the context of a stroke unit, and they do stay, on average, range between 10 to 20, even to 30 days, and they get the best results. So we come back now to our treatment. How do we manage? So we talk about stroke, so everybody should be in the context of stroke unit. Not everybody will get thrombolytic therapy. The maximum, the best countries in the world where they give thrombolytic therapy is in Scandinavian countries, Germany, the United States now, some states, for example, like California, almost 20-25% of patients with acute stroke get thrombolytic therapy. The average in the world is 2 to 4%, 5%. Here in Jordan, maybe it's 0.001% or something like that. Now, the important thing, the chain of stroke, we need obviously to work on many things. One thing is we have to recognize it, dispatch the patient once we recognize it, delivery, send it to the places where they manage strokes. You don't, in England and in Europe and the States, you only send acute stroke patients to hospitals that are accredited who can treat acute strokes. You don't send them to any hospital. So you should send them only to a stroke unit, a patient where you have that. If you send them in the UK, for example, there are accredited hospitals in London where there are accredited as stroke units. And everybody goes there. The ambulance will take them there. You will not take them to a hospital where they have no facility dealing with acute stroke. And that should happen here. So you should do the data, decision making. So time is essential. Time is brain. And you should really get the patient as quickly as possible within the window that you can give him the chance he may receive thrombolytic therapy and get a good outcome. So also we have to coordinate with the emergency services. The ambulance people have to be taught how to deal with these patients, what to do on the way to the hospital. They can save time by, for example, having a cardiac monitor, giving them oxygen, if hypertensive, maybe bringing the blood pressure up a bit, maybe do a glucose check on the way. If their blood sugar below 60, give them glucose, and then establish an intravenous line. Even take the blood sample. So when they go to the hospital, they can immediately save time by doing all these things. And they shouldn't do all these things. So basically, we should have coordination with the emergency services. And I just put this up. There was in the British Medical Journal in August 2002, management of patients within a stroke unit. This is now standard practice all over the world. It says every patient with a stroke should be treated in a stroke unit. Every patient with a stroke should be managed in a stroke unit. Okay, period. This is now gone. This is established treatment. It saves lives, increases the number of independent survivors, and reduces institutionalization. So these are now part of the national guidelines, and it should be ours. Now, why why putting patients in a stroke unit helps? And the reason is this. As you can see, there's a lot of difficulties about how to interpret this. But basically, patients on a stroke unit, like here, and compared to the regular ward, for example, is that it seems they use more antibiotics. Aspiration prevention is much better when you are on a stroke unit than if you are on a general ward. Fluid management is better. Insulin is given more often. Control of diabetes is better. You give them more oxygen. You bring their temperature down a bit. If their temperature, high temperature is deleterious to the acute stroke. So you have to bring their temperature down. Tube feeding more than in the ward because you're preventing aspiration, one of the complications of the stroke. Urine catheter, less than on a ward. In the ward, they put a urine catheter and they just go away and look at that. And this is neurologically, all these things, especially the most important one is stroke progression recurrence. That is really much better managed than if you put it on the stroke. So basically, all these things, you do a lot of things better when you are treating patients in the context of a stroke. And this is the general management. I don't have time to really go into detail. I want to just go quickly forward to just give you a bit of an overview of the other things that we might be doing. But basically, when you have somebody on an acute stroke unit, you manage everything better than if you have them on a general ward. So what about blood pressure? One of the problems also in our country is how to manage blood pressure in a patient with an acute stroke. And what we always do, a lot of us do, is we bring the blood pressure straight down. And I've seen this done in the emergency room very often. And this is the worst thing you can do for a stroke patient. If the patient doesn't have hemorrhage, you should not touch the blood pressure, even if it was 220 over 120. If you're really worried, you are allowed to bring it down 10%. Don't bring it down, because you will make the stroke worse. Okay? And this is a standard sort of treatment. And if you have it, then the best drug to use is levetiracetam. nicardipine, and enalapril, and sodium nitroprusside. I mean, here in Jordan, we use a lot of Isokit, for example, which is not the best drug to use to bring blood pressure in this situation. What about osmotherapy? One of the things that very often here is done, given mannitol, steroids, all this now has been found to be irrelevant, and we should not use steroids in treating acute strokes. We make patients worse, actually. We increase the incidence of infection. So all of these, doing, for example, changing temperatures, but basically to reduce intracranial pressure, there's a lot that we can do. A lot of previous practice we used to use that isn't anymore standard practice in the world. Now, I just want to talk briefly about TPA. Now, TPA, as I mentioned, the first time that I heard about TPA in stroke was in '89 by Professor Fred Plum from Cornell University, New York, at the World Congress of Federation of Neurology in New Delhi. And he presented the first case. It was dramatic. And I went to him after the talk and took the protocol. And according to this study, the NICE trial in the States was started, and it was obviously published in 1996. Okay. Now in Jordan, as it happened, I used TPA. I was faced with a 45-year-old patient in '94, who the wife of a doctor who had a complete dense hemiplegia and aphasia, and we used it in that context with him consenting to it, and she had an incredible, very quick recovery. So basically, there's no question whatsoever that now TPA is a standard treatment in eligible patients. And so I'll go very quickly forward. So 96, NICE trial, Canada 99, in the UK and Europe. In 2002, they approved it in stroke. The ECAS trial is, they extended the window from 3 hours to 4.5 hours, and the ICT, the International Stroke trial, the third one, 2013, they think it's 6 hours. But I think there's a big controversy about this, and I think we have to wait and see. We need more studies. Now, this is just to emphasize that earlier you treat the patient within the time window of either 90 minutes, you get better outcome. And these are inclusion criteria, exclusion criteria. I will not take your time on it. But basically, the important thing, you have to have a protocol if you are going to set up a stroke unit, and they have to follow this protocol strictly. And compared, this is the ECAS trial. I already mentioned these differences between the ECAS trial and the NICE trial, how you choose the patients. And this is one of the things about aspirin and clopidogrel. You know, we've had this debate about, do you use clopidogrel and aspirin, okay, in acute setting? And this is a trial that was published in July 2013, and this is basically a Chinese trial, where they did it on 5,000 patients. And one patient with TIA or minor stroke who came to be treated within 24 hours after the symptoms, the combination of clopidogrel and aspirin is superior to aspirin alone for reducing risk of stroke in the first 90 days. So what they did, they give patients clopidogrel and aspirin for both of them for 90 days. And there was a double-blind trial. The other side took aspirin alone, and they found that there is a difference between the two, and it is. But this is controversial. It is not standard practice, and certainly there is no evidence whatsoever that long-term use of clopidogrel and aspirin is beneficial in patients with stroke on a long-term basis. But this, we may hear more about this, about the use of clopidogrel and aspirin in the acute phase and in a short period of time. So the anti-edema drug, we mentioned about, I was talking about the, sometimes we are faced with patients who have a massive NCA occlusion, and you have edema. So what do you do with these patients? There's no doubt now, it is standard therapy, that the best way to do it, it is anti-edema therapy. First choice, craniectomy, hemicraniectomy is the first choice for patients with large middle cerebral artery infarction, age 60 or younger. And the Destiny 2 trial suggests that, in fact, you can extend this and choose the right patient. And basically, this is showing you survival from 3 trials. There are small trials, but following up, there is quite significant difference in the outcome of these patients. So this is the Destiny 2 trial, having very increased survival without severe disability among patients 60 years old, 61 years and older. The majority of survival required assistance to most bodily needs, and here you can see the difference as far as survival is concerned. Future treatments, intravenous, intraarterial. There's a lot of work going on in this field. mechanical thrombectomy, ultrasonography in hospital, urgent carotid endarterectomy, tracheal stent placement. And so in conclusion, sorry I've taken maybe a bit of time, the most important thing is to recognize stroke, symptoms and diagnosis. This has to be done for the public, the doctors, and then we have to do it across the emergency services to tell them how important it is to recognize stroke and to really act quickly. Thrombolysis with alteplase should be administered to HME patients only within a well-organized stroke service. It should not be used independently by certain doctors in any hospital. It should be only done in the context of a properly organized stroke service. Specialist care for people with acute stroke, obviously this is something. Thank you for your attention.
My question is regarding the duration of the treatments. For using monotherapy, for how long will you try monotherapy before deciding to use dual therapy?
Yeah. Well, it's a difficult question, isn't it? Because if someone is having frequent seizures, if they're having 2 or 3, if someone was having 2 seizures a week, and you gave them monotherapy and it wasn't working after 6 weeks, and you pushed up the dose, you might do something very quickly. But if someone has 2 seizures a year, it's quite difficult to know if the drug's working or not. So it's a bit difficult to answer that question. I think it's about whether the patient's satisfied with the seizure control that they've got. If you're satisfied that you've pushed the dose up sufficiently to a dose that they can tolerate, and it's not working and they're still having seizures, it's worth remembering that 17% of patients should be rendered seizure-free by medication. I didn't say that, I should have said that. So, on balance, you should be expecting this patient to be seizure-free. If they're still having seizures, you need to keep trying. That would be the general principle.
My second question, sometimes the patient responding to dual therapy and the frequency of the epileptic fit will become much less frequent. In such cases, we can say that we are still not reaching a successful treatment in such patient, and we need to change the line of our treatment, or this is accepted, I mean, from clinical point of view.
Yeah, no, I think, well, again, it depends what you've already tried. But so for example, if it's their first adjunctive treatment, they're on 2 drugs, their seizures have improved, they're happy, but they're still having them. I think that's not a good outcome. I think you need to keep going because the studies that we've got showing what happens to clinical populations of these drug-resistant patients is that quite a number of them do much better if you try harder. It may be that the drug you gave them is working, but they can't tolerate a higher dose, or maybe they need to try a different one and then see if they can manage that one at a higher dose. At some point, you have to say to the patient, look, this is as good as we can get it, but I think there is a tendency to not probably push as hard as we should for particularly higher doses. It's not so much trying lots of different drugs. I think it's just probably not trying the drug at a high enough dose.
Thank you. Any other questions? I have a very short question for you, Dr. Stone. Yeah, very good question. Is there any place for a drug treatment in functional neurological disorders? I mean, antidepressants, neuroleptics, etc.
Yeah, that's a good question. I think in terms of evidence, there's no clinical evidence for trials for that. My practice is to use antidepressants if someone has depression or anxiety, and probably about 40 to 50% of patients do, so you end up using them quite a lot. But I'm not convinced that there's something that's something we should just give to everyone, regardless. There are those patients who have these symptoms who are not particularly anxious or depressed. So I think base that decision on their other symptoms. Are they sleeping? What's their mood like? Do they have anxiety? Rather than their neurological symptoms. Probably slightly different for non-epileptic attacks. I would have a higher threshold there because I think non-epileptic attacks in some patients are very much a form through sort of panic attacks and can be treated that way.
Thank you, Dr. Armstrong, for this nice presentation. And I think it's attract attention, not only the neurologists and medics, but psychiatrists as well. And really very interested, terminology. In 1970s, 50s, they labeled these symptoms, which is unexplained, as psychogenic. And nowadays it is unexplained medical symptom or functional. And I think that we are back to the era even before Freud's and Charcot. And there is a mislabeling in the 1970s when they labeled these symptoms as psychogenic. My question, do you think that these unexplained symptoms, which is not universal to neurology, but we found these symptoms in other medical specialties, do you think that in view of development, I mean neuroimaging studies and finding positive signs in neurology for these symptoms, do you think that one day that comes to find a real explanation for these symptoms? And the second question, we have a problem in following these patients, especially chronic unexplained motor and sensory symptoms, and they just keep running between neurology clinics and psychiatrists. And in view that we don't have the well-established GP system like in Jordan, like in UK, do you advise to see these patients in psychiatric or neurological clinics, especially the chronic cases? Thank you.
Okay, I'll deal with that question first then. I mean, most of the time they're not seen by anyone, are they? Sorry, I think most of the time nobody's got particular interest in them. What I think goes wrong in the UK, at least, is that the neurologist or the physician may make a diagnosis, but doesn't explain that to the patient. I think we really need to move away from the idea that these things are unexplained, okay? Because I just don't think that makes any sense. So if you look at migraine, for example, we're all happy that migraine is a disorder. You diagnose it based on a story. Someone has a throbbing headache, you want to go and lie in a dark room. But you can't see anything really there's nothing to see on a structural brain scan in migraine. We know something about the disorder of function in the brain, but it's still a lot's unknown. We don't really know why people get migraine. Migraine is influenced by stress, sleep, etc. But we're all quite happy to call it migraine. We don't call it an unexplained syndrome. So I would like to see us thinking about these disorders, chronic pain, fibromyalgia, chronic fatigue, other functional disorders, irritable bowel, as not that they're not unexplained. We actually can recognise them and we know what they look like when we see them. Any physician knows what these things are when they see them. They know the sort of patients that get them. So we should not be thinking these are unexplained. There are things about them we don't know, but I think that applies to all of the diseases that I look after. So I don't make that separation that you make between unexplained and explained. And if you do that as well, it also has implications for your practice. You think, well, these are disorders within my specialty, and just like someone with MS, I might see someone with MS chronically because they have lots of problems and they're going to benefit from seeing me, but I might not because it might be nothing more that I can do for them. So who should manage them? It depends if that person's helping them. If that person's helping them to get better, then they should see them. If they're not helping them, then they shouldn't, probably. But someone in the UK, it's useful to have GPs who protect those patients from harm. So they do come to harm from surgeons, from over-investigation. People don't realise they've got a vulnerability to functional disorders in general. Did I cover both those questions? I think. No answer. I'm not sure I did. Perhaps we can talk afterwards.
Thank you, Dr. John Stone, for a very interesting talk. I want to ask our local doctors, Dr. Majid, for example, very simple question about the role of nicotinic acid deficiency. Nicotinic acid deficiency. Nicotinic acid deficiency.
One of the slides was on nicotinic acid is the other name of niacin, which is vitamin B3. Nicotinic acid is niacin, vitamin B3. Niacin or nicotinic acid. It's vitamin B3 is two forms: niacin, which is nicotinic acid, and nicotinamide, which is the amide derivative. And it's very rare in developed countries, but in developing countries, niacin deficiency results in pellagra, which is dermatitis, which I showed there, dementia-like syndrome, and if untreated, eventually death.
Yeah, I have a question for Dr. Maurice. It's a question. Are your results in your stroke unit, the success of thrombolysis, how they are compatible with the international results? Is it the same percent of improving patients, same percent of patients with the disability?
Thank you. Unfortunately, what we have, most of the patients that were treated in the stroke unit have been very carefully selected, and the numbers are not very high. So I think we can't recommend any conclusions, but I can tell you that at least the number of patients who had symptomatic intracranial hemorrhage is in conformity with the international literature. So the number of patients who had, that's better. I'll repeat. Basically, the number of patients who received thrombolytic therapy are rather small, although we're making every effort to get as many patients eligible as soon as possible to give them this treatment. The number of patients we thrombolized have done very well, and all I can say is that the number of patients who have symptomatic intracranial hemorrhage are in conformity with the international literature. So basically, they're less than 6 or 7%. And usually, these are patients. In one case, for example, I can remember the history was not given to us very carefully, and the others, there was simply either patients who would normally expect at least 7% of patients who have symptomatic hemorrhage. But in general, I cannot tell you because there are 6 neurologists who are interested, who have actually participated in treating patients in the stroke unit. The good thing about it is that there is a protocol that everybody follows, and we are probably on the careful side, which I think is the right way to go. But in general, I'm very pleased with the way it's running.
Thank you so much. I think you have to collect your data and have some sort of statistics. Any other questions? Maybe there's time for the last question.
My question is to Dr. Maurice. Thank you very much for updating us in the management of ischemic stroke. I have 2 questions. The first one, usually patients with ischemic stroke, these having a multi-risk factors, and especially diabetes, hypertension, dyslipidemia, and one of them is the target involvement is renal impairment. To which level that thrombolytic therapy is safe to be given in a patient with renal impairment? Which stage of chronic kidney disease? This is number 1. Number 2, a patient with past history of hemorrhagic ischemic stroke. What is the precautions, and is there any relative contraindication to thrombolyze such patient?
Thank you very much. Now, as far as patients with chronic renal failure, if the patient, it depends really on how you choose the patient. But in general, as far as I can remember, we haven't treated anyone who was actually in chronic renal failure on dialysis, for example. But we have seen patients with impaired renal function. And if they are eligible for treatment, you just treat them as you would with other patients. And obviously, you may carry a slightly bigger risk, particularly if their blood pressure is not very well controlled, or if they are diabetics. And I think you have to appreciate that patients who are diabetic and uncontrolled hypertension, they have a higher risk of intracellular hemorrhage. But if you are faced with a patient who has an occlusion of the middle artery in the dominant hemisphere, I think if you put the pros and cons, you will find that there are, that you probably would go from the license. But I think you have to choose your patient carefully. Now, the other question you asked about
Patient with the past history of hemorrhagic stroke.
Yes, if you have somebody with a previous hemorrhagic stroke, I think he is an exclusion criteria.
Hemorrhagic ischemic, not hemorrhagic.
No, sorry, if he has an ischemic But you see, if there is any evidence, this is one of the exclusion criteria. If a patient had a previous stroke with hemorrhagic transformation, I think you have to be very careful about that. That would be an exclusion criteria. Now, you can do special brain imaging where you can become microbleeds. I think this is one of the eras where we're going into better imaging for patients. And if you find microbleeds on these patients, there is maybe some evidence that these patients should be excluded because they carry a high risk of interstitial.
Thank you very much. I think our time is over. Now we want to thank our lecturers for their excellent presentations. And Dr. Mike, Dr. Johnson, thank you for your excellent presentation. Thank you for your excellent participation and really very important lecture. And I would like to thank the audience.
Doctor, excuse me, bro.